co-director of the Philoctetes Center. As I said before, Dr. Ed Rusessian is his co-director. I had made previously the announcements about our forthcoming program, which I would love to bore you with again, but I won't do that. I just wanted to say that I really was very honored to have the group of actors who did the performance of Philoctetes. It was an amazing, really an amazing rendition of the play. That provides obviously was the basis for the naming of the center, and it's really the subject of our discussion here today, the play influencing that discussion. I'm now very honored to introduce Lyuba Konopasek. Is that the correct pronunciation?
Yes.
Really? Associate Professor of Pediatrics and Director of Pediatric Undergraduate Medical Education at Weill Cornell Medical College, and with whom I also attended a previous Philoctetes panel session. And I think you have a little bit of a sort of kind of surprise idea that you're going to tell us about in a couple of minutes. But her other, to continue, her particular interest is in medical interviewing and the physician-patient relationship, and she is developing a longitudinal 4-year communication skills curriculum at Weill Cornell. She is also interested in the integration of the arts and humanities into medical education and leads a collaboration between Cornell and the Frick Collection to increase students' clinical observational skills through the study of portraits. Now, Lyuba is going to moderate today's panel and introduce our other distinguished panelists. Thank you.
Let me introduce you to Jonathan Jacobs, who is Executive Director of the Center for Special Studies at New York Presbyterian Hospital, Cornell campus. He's a professor of clinical medicine at Cornell. He hails from Yale University School of Medicine, where he went to school and completed his residency training in internal medicine at New York Hospital. He subsequently trained in the subspecialty of infectious diseases at the same institution, and he's been a clinician, administrator, and educator for the past 21 years with a particular interest in HIV. Welcome. The next person I'd like to introduce to you is Dr. Bob Michels, who is the Welsh McDermott University Professor of Medicine and Psychiatry at Weill Medical College, and the training and supervising analyst at the Columbia University Center for Psychoanalytic Training and Research. Bryan Doerries is a New York-based writer and director. Over the past decade, he's directed many of his own translations of Greek and Roman plays at theaters and universities across the country. Recent theatrical projects include The Bacchae of Euripides, Sophocles' Ajax, Antigone, Women of Trachis, Bloodhounds, and Philoctetes, Seneca's Phaedra and Octavia, and Virgil's Aeneid, Book 4. He has a BA in Classics from Kenyon College and an MFA in Directing from the University of California, Irvine. And finally, Dr. Lou Pangaro, who is a professor and vice chairman of educational programs in the Department of Medicine at USIS, the Uniformed Services University in Bethesda, Maryland. So, we were thinking, as we were thinking, how are we going to move the session from downstairs and the reading that you just heard up to here and the conversation, how are we going to engage all of you? And Bryan and I were actually talking about the notion of creating a sort of Greek chorus, if you will, Quaker style. So what I'd like you to do for a moment is reflect on what you just heard, what you just saw downstairs, just for a few minutes, and think about how it relates to your own experiences as a physician, caregiver, patient, anyone. Okay? How does it relate to your own experiences? If you have a piece of paper and a pencil, you can take it out now. Just jot it down. Okay? Okay.
There are always predators ready to mislead us and steal what we have.
I like that. That's a good one to begin our conversation, I think. I like the predator idea. And I thought I'd pose that. It's a good provocative question to pose to our panelists. Did that resonate with you? Have you ever, so most of our panelists are physicians. And our charge is to talk about caregiving. Is our caregiving necessarily benign and patient-friendly?
I know mine's not. But obviously, medicine is complex, and while one would like to think that people choose medicine for altruistic reasons, there are other reasons to go into it as well, even some predatory ones, if you extend that far enough. The purpose of the relationship is not always to simply help the patient. If you are a clinical investigator, you're trying new therapies which hopefully will help others, but not necessarily the patient. There is always the financial aspect of it. So, if you get one more test on somebody, maybe it's necessary, maybe it's not. Maybe you enrich yourself, but it is by no means a unidirectional relationship.
I made up two lists when you asked your first question. One was what's similar or parallel to the doctor-patient relationship and what's different in the play. My first response when I heard the two were being linked, this discussion in the play, was that I was troubled, because it seems to me there's no doctor in this play. There's a patient, but no one I would think of as a doctor. And in that sense, the play is pre-Hippocratic rather than parallel with Hippocrates. So you have someone who's suffering and in pain and desperately needs Jonathan, an expert in infectious disease. It would probably take him about 20 minutes to, he would have cured the patient before you finished the play.
Actually, I think he needed the psychiatrist more.
I think if we gave him a choice, Jonathan, he'd take you rather than me. But there's no treatment. There's no doctor. And that's not represented there. Mm-hmm. And in a way, the doctor touches on the question of mistrust. So I would, one simple-minded understanding of one theme in the play is his total helpless dependency links to excessive trust, mm-hmm. links to betrayal and frustration, mm-hmm. links to paranoid mistrust. That's a normal sequence. Mm-hmm. And one of the functions of the medical profession is to provide the patient with some assurance of a certain level of trustworthiness. So I think Jonathan was kidding. Mm-hmm. If I were sick, I would go to him, and I would know he's making money on the side, and I would know he might want to do a research project. But I'd also know that he's been, I think at Yale, certainly at Cornell, extensively socialized to be my fiduciary, to worry about my needs and to prioritize them. And that I would also know that his colleagues would look on him with contempt if he violated that. And that would give me a level of trust that I wouldn't have had 2,600 years ago.
My initial reaction was the same as Dr. Michels. I said, what is the analogy here? But after a while, I began to see my own students' problem. Lyuba and I are both very involved in medical education, so the problem of Neoptolemus, who's caught between the masters, the attending physician, the hospital system, the professors, people like us sitting around the table, and the patient seemed to me to be a real one. And we know from a lot of work with students, published literature on students, that they do feel caught in between. That we, as the teachers, don't really understand what we're asking them to do, the socialization, the professionalization, as they see it early on, means a loss of a certain sense of humanity. Now, they get through that. That's a phase through which they get. They understand that the faculty, the leaders, are actually trying to act on the patient's interest, but that there's a certain dispassion that is necessary, a certain coolness. Equanimitas was the term our great mentor Osler gave to it, that you needed to be somehow dispassionate and to see the patient. But it's a very difficult thing for the student to go through, and Jesse, in acting this today, really caught that sense. I saw my own students in this poor guy who was caught in between, and the word that was used, predator, was really, God, it scared the shit out of me when you said that. But you know, when you're a patient and you feel that, and I think you're right, the patients do go through that. But from my perspective as a medical educator, I saw this as a really valuable thing for my students to see, that we understand the situation that they're being placed in. And the honesty with which he eventually responds to Philoctetes almost creates the turning point. He passes the test. I mean, that's really what happens in the play. Philoctetes is a test for this student, for a Neoptolemus. He passes it. And his finally making that decision becomes healing then for Philoctetes, and allows the Hercules appearing is just the way that happens. But it allows the patient to accept it too. So even though I was at first didn't understand the analogy and what this whole discussion was going to be about when I was invited, I said, boy, this really worked. And it was really, I thought, remarkable situation of what the young person caught between the system and the patient, perceiving the system as somehow predatory, hostile at best, really fit this medical education model.
I guess thinking more about Neoptolemus, one of the pieces that I always wonder about is what that experience was, and we're sort of talking about the negative sides of the physician-patient relationship. I think we'll move from there, but the lying piece, was it easy for him? Was it hard? The notion of for the greater good, do we buy into that? Is lying to our patients occasionally necessary? For the greater good, or perhaps even for the individual good of the patient.
Or for the hospital.
For the hospital. Which sometimes I compare the Argive army with the hospital.
I think in a well-run system, and that's a big if, you shouldn't have to lie for your patient except for the patient's good. The doctor shouldn't be, there may be lies that are perpetrated, but not by the doctor or not with the doctor's consent. But lying for the patient's good is tricky because it implies that there's an objective definition of what's a truth and what's lie, and then you do the lie rather than the truth. And that's only true in the abstract. The question of a lie usually amounts to the truth value of what someone says. But in clinical medicine, the critical issue is the truth value of what someone hears. And that's not the same thing. So if a patient says, "Doctor, tell me the truth. Do I have cancer? If I have cancer, I'll kill myself." What is the meaning of "you have cancer"? I think you should kill yourself? Is that the truth? Is it a lie to say, now let's talk about it some more and you have a tumor but it's hard to specify? Or is that saying, I think you should live? So it isn't as crisp as our denotative adherence to the dictionary would suggest. But the purpose of the lie then is the patient. I get uneasy if doctors lie for hospitals or healthcare systems or insurance companies or their personal income or stuff like that there.
What about when the doctor has to get information from the patient that might benefit the society? A patient tells a psychiatrist he's murdered or he's going to, there's a confidentiality. what about that situation? And the patient says, if I tell you this, can I trust you?
That's a sharp, clear question, and the clue to Jeffrey not totally analyzing it is in a careless or in the middle of it. He says, if the patient tells the doctor that I've killed somebody or I'm going to, as though those were roughly equivalent statements the doctor would deal with in the same way. But 100% not at all. The doctor has no role in bringing punishment to the guilty. He does have a role in protecting. If someone's killed someone, what good does it do to tell the secret? Who do you save?
The society from that person.
How do you know they need to be
That's
saved?
what I'm saying, would you think that?
It wouldn't cross my mind if someone said, I killed somebody. We had a patient in a local hospital a while back who told the staff that he had committed murder 20 years earlier. And some of the young students thought they should call the police. And it took some wiser heads to point out that that would be a terribly unethical thing for doctors to do to a patient. On the other hand, if the patient says, I'm going to kill somebody, you don't have to go very far to decide that it's in the patient's interest that you do something to stop it, as well as in society's interest. So the theme is saving lives, not punishing guilty.
That's an interesting point, because it's a little different than I think that often we think of the people in greater positions of power and authority as thinking about the whole system, whereas sometimes it's our foot soldiers, our residents, our medical students who are spending most time with the patient, who really are thinking about the patient and their situation. So that's a slightly different piece.
I don't think I'd agree with it. I would say the system only works if people trust their doctors. And therefore, the reason I would not tell society that somebody killed somebody is for society. So that when those people in society, all of us that is, go to our doctor, we know that the ethic of this profession is such, so I can be comfortable sharing my secrets with my doctor, knowing that he won't have some misguided notion of doing what's good for mankind, even though it hurts me.
One less clear-cut situation, or perhaps more clear-cut situation, is something that I would think that you would encounter all the time when you're dealing with parents who tell you that they are abusing their children. And, knowing you have to act on that confidence, but also knowing that it will probably destroy the relationship that you have with your own patient. Something that we deal with all the time.
But it's in the patient's interest to have that confidence divulged.
Yeah, I mean,
not necessarily if they have their children taken away from them.
I think it's not healthy to hurt your children.
I agree.
Can I pose a question? So, when you were touching on the patient's self-reporting of I have murdered someone, I'm going to murder someone, that resonates for me with something that happens in the play quite a bit, and something we've talked about with medical students as well. The self-reporting of data for which you have no verifiable means of authenticating it, namely pain, and the self-reporting of pain. Now, Philoctetes spends a great deal of the play in agonizing pain. And one of the things with the actors that we start off each rehearsal when we work on those sections talking about is, do you believe Philoctetes?
At what point?
At what point do you not believe Philoctetes, and why?
He looked very perky at the beginning, right?
Now,
and it was interesting how he was really building the relationship.
Now, I raised that because I've spent some time on hospice wards as a caregiver. And I've been in the room when doctors have had to deal with patients who are asking for morphine because they are in excruciating pain. And those patients have developed resistance. They've developed an ability to take 20 times a lethal dose of morphine. And they are self-reporting, I'm an 8 on a scale of 1 to 10. And the physicians are giving the equivalent of what you give someone if they said they were a 2 or a 3. And there's an ethical bind there.
Why do you think they do that?
Well, my experience in the hospice ward is because they're afraid of killing a patient who's already signed a DNR. And the word palliative care, which comes from a Greek word that means to make easier, when I go to the Jacob Perlow Palliative Care Center, or whatever it's called, flashes of this memory come back to me of nothing being made easier about the process of dying by patients self-reporting pain and doctors either disbelieving them because they have no way of verifying what they're saying, or thinking about the insurance costs of having another person die and having an angry family not understand.
Well, I think that there are a few other elements there. One is who the patient is, because if you have somebody who has abused drugs during their life, even though they're really having pain,
Seeking.
Right. Are they seeking medication? And that's a huge problem that we have. But we also have the problem that's raised by the play itself, where he says, cut off my legs or put me under the ground. And the next day, or the next line, he says, it's beautiful, this light of dawn. So, who are you going to address at any given point, knowing that the situation, can change?
Yeah. The one other piece that I want to take off on that is someone talked about the ambivalence of the illness for Philoctetes, and I think that relates nicely to this conversation about the pain and how much medicine you want and how do you get it, and sort of what are your thoughts about Philoctetes? At one point he says it's not the past that haunts me but the future, and I think the context perhaps was the future of living with the people who had wronged him. But I also wondered if some of it was the future of living without this disease that's been my companion. The only companion I've had, and incidentally, the only female element in the whole play.
All male play, yeah.
Right? He says, pain, she comes, which I thought was interesting. So his companion of 9 years, that ambivalence, I wondered what you might think about that.
Well, he says at one point, there is no I, only it, meaning my suffering. So I think you're right that many patients almost consciously or otherwise become reduced to being what they are, and that's who they are, that's how they get attention. And it's part of our job as physicians and educators to help students see that as a phase through it, or a state through which you have to try to lead somebody out of. That it's not a good state to be in. That if he doesn't accept treatment, if Philoctetes for some reason doesn't trust them, that there is in fact cure in Troy. If he goes back, he will be cured.
Purportedly.
Well, that's. I think it was a given, though. You have to help me with the script. I took it as a given in the play that there was, in fact, a cure for him.
Yeah, there are classicists in the rooms. I'm going to be careful about what I say, but I, as a director, as a translator, as someone who comes to the Greeks to work with actors, we take nothing as given. And this play is built on an edifice of half-truths. And it's impossible to know when people are telling the truth and lying because the lies are predicated upon using the truth to tell the lie.
But in your intro, Bryan, you said we should take it as a given.
I gave some circumstances.
Yeah, there are circumstances.
Those are circumstances that we, the actors and the director, agreed to for this particular presentation. But there are just so many variations on the myth. And we have so little commerce with the people who passed it down 2,400 years later. Aeschylus had a version, Euripides had a version, Sophocles has a version, Andre Gide has a version, Heiner Müller has a version, and they're all taking a series of different given circumstances as self-evident.
Okay.
Those are the ones we took.
It's like a White House press conference.
Greek myths, yes. Full of Greek myths.
I was struck by, I think that moment that you talk about where he's promising a cure. I thought that was very interesting because I wasn't sure whether to believe the given or not. And I'm always struck by how we give information to patients. How much of it we believe ourselves, how much of it is our hope and our faith. And I was also struck this time particularly that Philoctetes did not buy it. He was so convincing, and Philoctetes did not buy it. He wasn't going to be going to Troy. And that it took that Deus Ex Machina, God coming down, for him to believe it.
Yeah. Well, I wonder, about that. If well, I wonder about the subject of non-compliance, because it seems like there are so many diseases out there that, I mean, some of the statistics I've read, and again, there are doctors in the room, so please correct me, but there are many diseases that plague modern humanity where predominant amount of patients, over 50 or 60%, are non-compliant with the treatment.
I would correct one thing, which is, again, in my field, in particular in HIV, we've gotten away from the term non-compliance.
Thank you.
Now it's non-adherence.
It's like coming together rather than bending.
So, you know, we're not victimizing the victim.
This is a White House press conference.
Yes, yes.
No, I understand.
Yeah.
I apologize if I offended anyone. But that being said, non-adhering patients, you know, adolescents who are so, as Lyuba works with pediatrics, who are so unlikely to take the medicine that they've been prescribed in a regular way, diabetics who let their insulin get out of control, lung transplant patients who smoke cigarettes because that's a means of control over the fact that they're in this position. You know, I wonder about that issue of non-compliance and what you heard in the play today with your experiences as physicians.
Well, it was contaminated here because Philoctetes has feelings about the system, which he thinks has been grossly unfair to him. So to some extent, his willingness to go along with what might be a treatment has to do with his acceptance of the people who have victimized him to begin with. So I'm not sure it's directly analogous, but certainly patients often feel victimized. Again, whether you see this guy as a veteran of the wars, I should say I work at Walter Reed Army Medical Center. I was 20 years in uniform as a military physician. My wife and I work at Walter Reed Army Medical Center, where there are young men and middle-aged men and women with wounds that are festering in their legs because of explosive devices. And some of them are lucky in that they've had amputations and they don't have legs or arms anymore. And I use the word lucky advisory. This is a very painful play for us to watch because of that analogy. And some of these veterans feel terribly victimized, not by having been there, but by what happens to them when they come back. Most of them feel that their lives are saved and they got good care, but once they got past the doctors into the system, the medical care, and you know, you read the New Yorker, the picture on the front of the magazine in March was very painful for us because it looked like the doctors were abandoning the patients, and it seems to be the system beyond that. But it's very difficult when you feel like you've been in combat or something. You were there helping the mission. You went to fight the Trojan War. The society had to do it, and then these people screwed you, and they're not taking care of you. So I can see how Philoctetes, can say, why should compliant, adherent, whatever jargon you want to use, why should I trust these people?
Well, it's another reason why he might say it's not the past that haunts him, it's the future. The future.
There has to be, and I think you were saying this before about that. In order for us to take care of patients, to play our role, whatever that role is, there has to be this bond of trust. I mean, I don't imagine there's anybody in this room who hasn't been a patient at some time. I know when I go to my car mechanic, I say, do I trust this person? You were talking about they profit from changing my tires, my axles. Imagine how you feel if you don't trust your physicians. And if the whole system is out to get you. So I'm shocked how apposite, how this play resonates with us at this point in time. It's a little scary for me.
One of the things we were wondering if you could address is what you just said about the fact that there are situations that is painful for the physician.
Yeah.
And how do you, especially in your position at Walter Reed, how do you handle those?
This play gets it. There's two aspects of the pain. The thing that struck me is what Odysseus is arguing for is the greater good, the mission. I mean, Odysseus is always the guy who lies and says to lie, but I'm going to, for purposes of the discussion, say that he really believes they need to win this war.
Sure, he's saving lives.
It's been going on for 10 years. It will save lives if we can even if we have to dupe this guy, there is a greater good here.
They're all right.
Yeah.
They're all right.
And so one of the problems that we always have, and in the military, it's very clear, the mission comes first. And the pain of the individual, whether it's my own as the physician or the individual, is secondary to the mission because we believe we're serving the greater good, the country. As you probably know, the military for many years doesn't make these decisions about what happens. It's the government. It's the people who are now dressed in ties like I am in the Pentagon or in the White House who make the decision. And you are supposed to put up with your own personal pain or accept the pain of your patients for the sake of that greater good. And what is supposed to help us is the Geneva Convention that says that there are certain rules. For 20 years I carried a card in my pocket that said there are certain things I must do and certain things I may not do.
Have you thrown it away?
It's a collector's
Well,
item.
once I retired from the military 10 years ago. But it's I'm not being facetious when this is a very difficult question for physicians in the uniform at the moment who are trying very hard to behave ethically and to put up with things that they're not sure about.
Yeah.
An aspect of trusting the physician is the message parallel to the patient who says, I'm going to suicide. So it's the cry for help. The same thing as you were talking before about the patient who confesses child abuse. Could be, even if they knew the legality of reporting, it could be a message to the physician, can you find some way out of reporting me to help me just get out of the situation or something to stop me. One other question. I'd be interested in what the actors have to say about the issue of manipulation and truth, going through the experience of it.
So I'm going to just one piece. Do you want to?
Well, no, I was just going to say that in general, it's best if you have a comment to make it the microphone. But generally, what we do is we have the question period after the discussion is. But you can sort of carry that. But it's better for the people who like to speak to come to the microphone. It's recorded, and otherwise it's not.
I want to go back to where we were at this point,
Right.
which was we started with the tension between we started with the issue of non-adherence, non-compliance. And we took up two extreme cases of it, which is the patient who doesn't follow the doctor's orders, if it's compliance, or the soldier who is torn between the mission and his personal safety or health. But really, it's a universal situation. Who has never not complied with what he was told to do by parents or the school system or the government or society or the culture or whatever? And I think who hasn't felt betrayed or in conflict over their personal interests and the greater good? And so those are universal situations. And all you have to do is look at the incidence of obesity or poor diet or non-exercise or terrible self-care. The last estimate I saw, 50% of the total burden of illness is due to behaviors. Drinking, smoking, addictive behaviors, non-adherence to medical regimens, whatever. So this is a universal theme of being human rather than a special circumstantial theme of being a patient or a soldier. And to me, this is where we, again, can go back to what's the medical profession all about. Because the difference between 2,400 years ago and now, one difference is that we've reached a cultural decision that it's for the greater good to have a designated group of people whose mission is helping the individual rather than imposing the social order. So doctors emerge, and they're odd because they're certainly serving the greater good, but they're doing it by, in every individual situation, serving the patient's interest rather than society's interest. But the net effect of that is good for society. They're not unique in that. It's true of the law also, where we say we'd rather live in a world where every lawyer is working for his client rather than having lawyers impose what the society believes is best. Because in the long run, that'll be a better society.
Were you going to say something, Ryan?
Yeah, I think Bob's analogy and description of the situation is right. However, I'm worried about the evolution or the change in the medical profession here. There are mandates now about seatbelts, right? And we say that the individual is important, but there could come a time, because of the increased cost of medical care, where the government may say to the individual, if you are not adherent to your medications, if you do not control your diabetes, your asthma, we're not going to cover and pay for your medical care. And that all of the society is going to be involved in a discussion about whether or not we're going to pay for the medical care for the non-adherent. And that physicians will be agents not in the future of the individual, but more directly of society.
Still, the caretaking physician doesn't worry about who pays and who doesn't. That system does. But by the time you're the doctor to a patient, most doctors I know don't fail to treat the patient because the patient can't afford them. If the patient gets in their office, they treat them.
Unless the lady at the front desk turns the patient away because she doesn't have the right card, and I have had this happen to 3 friends lately in physicians and dental offices where they had a long history and were very well known. And when they got to the doctor himself, he was terribly mortified. Oh, I would never turn you away, dear. But you would let the lady at your front desk handle that for you.
So just to kind of add one more piece, the notion of adherence and pay for performance, so that physicians are actually going to feel fiscally the price of their patients' desire to adhere or not, which I think is going to have some grave implications for the medical encounter. And it's also going to add, I think, to what you were just saying. You were saying that that you might be turned away at the desk. It's interesting that when I first heard about pay for performance, I thought, great. This is going to be, finally physicians are going to be encouraged to really communicate effectively. But I think the risk is that this might be another way to select against a certain kind of patient. For me, one of the pieces that is very interesting about this play is this question of who owns the illness. And in terms of with our patients, that question of their decision to adhere or not. And I think that's a nice question, actually, for Jonathan, given his work. What's your thinking about that? Who owns the illness? And you know, there's the micro question for the individual patient, and of course the public health issue. But what's your thinking?
Well, I think in terms of, again, my particular interest of HIV, we all own the illness, because as this play demonstrates, there's this snake bite that caused this pain, but it's really the social factors, the isolation that creates so much of this man's misery. So I think that you know, for any chronic disease, you probably have to consider it in terms of the social determinants. Again, it's impossible or very difficult in this country to take care of chronic illness for people who don't have insurance or are impoverished. I mean, there just aren't systems in place to do that. So again, I think it makes a difference, most of all to the individual, you know, what happens as a result of that snake bite. But I think that we can certainly, all of us, not just physicians, modify that suffering person's experience by the social reaction. And of course, you know, again, in terms of HIV back in the 80s or what goes on around the world now, it is that stigma, that discrimination, you know, don't get on my ship, that really helps to fuel this epidemic.
How do you manage the patient that refuses to take their meds?
Well, I think you have a couple of choices. One, you know, when I was earlier in my career, I'd get very mad at that patient not following my orders. But now I realize that in order to keep any chance of keeping that person in care, I have to work with them, try to understand why they're not adherent. Again, is it because, you know, Medicaid shut off and they can't get the papers together to get it back on? Is it because they are scared that someone else will see their medications? So I think, again, it's something you have to investigate. And, you know, we are not a nation of medically literate people for the most part. So we have to educate, because some people, you know, don't understand. I feel perfectly well. You know, I may have this disease, but I feel fine today. Why do I have to take this medication? And the fact that I know why they have to take the medication is a lot different than them knowing why they have to take the medication. So I think educating both sides is critical.
One of the things that I wanted to also bounce off of all of you, that resonates with what you're saying, is that one of the things, Bob, that I think has changed since 409 BC about medicine is just what you said, and also remarkable advancements. But it does seem, from a patient perspective and a medically, reasonably, from my perspective, illiterate perspective, that we are at a footnote juncture in the history of medicine, that we're 52 years or 53 years past the first successful kidney transplant, that we're now in the business of creating a permanent subclass of people who are neither well nor sick and live for decades having to worry about the question of adherence when they don't know when it's all going to end, where there's no cure at Troy waiting for them. Just this permanent state of limbo, being neither well, yeah, this bardo, this liminal state, this thing that really wasn't. I mean, certainly there, you know, the mortality rate was high for an infection in the ancient world, or for chronic conditions. So I wonder, you know, the question about adherence. I mean, HIV is a really great. You know.
From a epidemiologic point of view, what you're saying, I think, is that what people like Jonathan have done is turn acute fatal illnesses into chronic disabilities.
Absolutely.
And therefore, the community is now divided into two groups of people: those who are chronically ill and those who are not yet chronically ill. And that's it. You're either in one category or the other.
Yeah.
Unless you're one of those unfortunate people who's going to get hit by a truck before your 45th birthday. That's a very small group.
What about the professional patients, so the people who seem to almost exult in their kind of identity as being patients, and if they were to graduate, they wouldn't be cared for anymore. So, you know, you have people, I wonder if, and perhaps this is not, there's a bit of untruth in what I'm saying, but it is my perception that there are certain people who enjoy maintaining their relationship with the doctor and so perpetuating their condition. I'm not talking about chronic AIDS patients, but I'm talking about, you know, the kind of person who has a constant series of ailments, one after the other, from which they never seem to be, you know, the chronic, I'm going to step on some toes, the chronic fatigue syndrome group. People who report these strange conditions that are, you know, go on for years, that have no nosology, that's really...
You're not stepping on my toe. You're explaining to me why I'm here, which I've been wondering about. I'm a
Because of your expertise in medical ethics.
I'm a psychoanalyst. I consider those people chronically ill with a disease that I spend my career trying to treat. So somebody who craves the sick role has a fascinating personality disorder, and can be helped often. Fortunately, that particular disorder is relatively treatable compared to some of the ones Jonathan has to treat.
But isn't it getting harder and harder to see the forest and the trees with regard to, I mean, you listed a few ailments, and they're the ones that seem pharmaceutically driven, like restless legs, or, you know, but what I meant by footnote is it just seems like we're on the verge of every day discovering a new complex of interactions between genetics and behavior and conditions that result in another chronic name for some disorder that you didn't know you were living with until it was diagnosed. And where will it end?
I would phrase it somewhat differently. I would say you weren't aware of because you were dead. The average life expectancy in the United States has, over the last century, gone up about 15 minutes every hour. Startling. So a lot of those chronically ill people aren't people, in your metaphor, who otherwise would today be considered unlabeled healthy.
Right.
They would today be considered dead.
Right. But is it better? Philoctetes' question, I think, is it better
to be dead?
To be dead than to be sentenced to a life of chronic illness?
Well, actually,
that's a fascinating empirical question. Many, let's take the people who know most about it, physicians. If you ask physicians and describe some horrendous chronic illness, the average physician says, I've seen that in the emergency room in the hospital, in the wards, I'd rather be dead. But if you ask patients with that disorder, with the locked-in syndrome, who are on respirators, the great majority want to be alive. So the answer is, for the people who know the most about it, they think it's better to be alive.
Well, I might challenge the idea that the doctors are the ones who know most about it.
Okay.
I would say, let me make a few points. One is that your response depends on whether you can do what he says in the play, embrace your pain. Because if you can do that and somehow, as says in the play, through suffering achieve greatness, that's one set of people. Most of us can't do that. But one experience that is universal that is not exactly chronic illness is old age, because when I first read this, what I thought about in terms of lemnos was a nursing home, where, we used to have, when I was an intern, something called the screech sign, where you would take Granny to the emergency room and take off. And that's as close to what happened to Philoctetes as I can think of.
Oh, yeah. They burn rubber.
Right. And so you don't have to be, even if you're healthy, you can be isolated in a way that's very painful like that.
The other piece that I thought was interesting was the moment that Neoptolemus's view of the patient, Philoctetes, changed. It struck me that he was okay with the lie until he saw the screaming. Right? He was going along with it. Plan was proceeding according to Odysseus's greater good plan. And it struck me that it was the moment when he really saw a very overt sign of Philoctetes' pain that he suddenly realized his humanity. I wonder what you guys think about that in terms of if that happens in the hospital. Is that the moment when we see our patient's humanity? Or is that the moment that we dehumanize them?
Those are two different reactions. Hopefully, a doctor would sense the patient's humanity before that, and also would be able to maintain an optimal emotional distance from the patient in spite of that. So that I would say, if the doctor's too identified with the system rather than the patient before that, that's a problem. And if they're over-identified with the patient and lose their contact with the system afterwards, that's a problem. And maybe what medical education should do, if it goes well, is to facilitate an earlier ability to empathize and identify, and facilitate a later ability to maintain optimal distance at the same time.
I think that piece of training in terms of the boundaries is something that is not done explicitly in many parts of medical education except for in psychiatry residency.
But I think it's done implicitly in all clinical education. And I'm not sure explicit training in that is worth much. It categorizes the phenomenon, but I'm not sure it facilitates its actual practice very much. I'm a skeptic about it, I guess.
Do you guys want to respond?
Well, I think it's a great question Bob is asking about implicit versus explicit training in the humanities in medical school, the work that you guys are doing so actively. It depends. Some schools pick 90 to 95% so-called hard science majors, chemistry, biology. Very often the leading schools do that. And so many schools, to deal with that fact that they're taking scientists in, have introduced humanities in the first few years, certainly interviewing courses in first year and dealing with students. But I agree with Bob that we don't have the empirical base. We don't have the research to know what makes a difference. There is a move in the educational community in this country to try to get away from just choosing students who do well on multiple choice tests. On science, multiple choice tests as the principal criterion for getting into medical school. That the admissions process will somehow be changed. We know, for instance, that the medical college admissions test, the science part of it, predicts pretty well how you'll do in the first 2 years of medical school.
That's all.
But the verbal reasoning part predicts better in the third and fourth year. Is calculus, physics, and organic chemistry a necessary entry requirement for your physicians? I mean, this is a place where patients can probably make themselves feel better than somebody who's on the inside because they don't listen to us. There's so much inertia in the system, but many people are arguing that psychology and the humanities may be a more important criterion for getting into medical school than calculus. Most physicians, and I'm an endocrinologist, I do a lot with hormones, but I know that biochemistry is not necessary for most medical students to study. Even in medical school, much less organic chemistry or physical chemistry being a prerequisite. As you probably know, those things are done as hurdles to demonstrate that you have the cognitive horsepower to deal with the medical curriculum. But how much is enough? So back to your question, is it a given that medical students recognize the humanity of their patients as the default, or do they have to come to some point like Neoptolemus when all of a sudden they say, oh my God, that's a human being I'm talking to? I don't think we know the answer to that. We don't have good ways of selecting students yet, and we don't have good tests of any kind, litmus tests or comprehensive tests for knowing whether or not medical students are sensitive to that. And our admissions committees try really hard to do it, but I don't think that.
And I actually think that there's something about the training and the implicit learning, the learning through the hidden curriculum, what you learn through role modeling and what you see on the floors, what you see other physicians doing, that might actually, my first years would be like Neoptolemus. I don't know if all of us as third years, fourth years, and residents would be. You are taught different coping strategies for when your patient is in that much pain, and that's a troubling piece for me. On one part, on one hand, I see the need for us to learn coping strategies and the equanimitas that we were talking about to provide effective care. On the other hand, how do we do that and at the same time not abandon our patients at those very moments, right? Because Neoptolemus does have the option of just running away that moment. That he's got the easy, he's got, the system is telling him it's the easy piece. What do you guys think about that?
One positive development is that, at least talking about medical training, the workload has been reduced so that we have the time to be empathic with people. When I was an intern, there were people with leukemia who were suffering who took up a lot of my time. And, being pulled in another direction to do something else and spending time with this patient, it was not a very humanitarian way to train, I don't think. I think that would, so I'm very glad that work rules have abolished that particular conflict. I think that physicians also self-select for various fields. Again, I'm not going to say which fields people might go into if they find that they have a hard time empathizing. And it probably works both ways. I mean, you might go into oncology because you have achieved the equanimity, or you might go into oncology because you have this great passion for people who are suffering. But I do think that we sort ourselves out to a certain degree.
I think you're bringing up the concept that we call the hidden curriculum. Just for terminology here, what Lyuba is referring to is that the explicit curriculum is anatomy, physiology, biochemistry, medicine, surgery, pediatrics. It's basically the syllabus, the content you want students to learn, but students learn and residents learn. There are certain things you do. And if you refer to the Philoctetes kind of character, who for us is the problem patient, the difficult patient, the patient who's in pain, and if you learn that, oh, just, turf it to somebody else. Draw the blood test, do the CAT scan, let somebody else do it. If that's what your role models, the term Lyuba used, are doing, then what the hidden curriculum teaches you is that's what you'll be rewarded to do. What patients and society needs to understand is that by and large, physicians are not paid to talk to patients. In fact, the current Medicare rules make it very hard for internists, pediatricians, I can't speak to psychiatrists, but if you spend time talking to a patient, you're taking that away from your income and your kid's tuition for college. The Medicare rules very explicitly punish physicians who are talking to patients. You are I'm speaking for myself here, not the United States government. The hidden curriculum teaches you order tests. Somebody else's time is being used. If Medicare pays you for 9 minutes for my patients are 75 years old, have 7 or 8 problems. I need a half an hour to 45 minutes. One of the great things about the federal government, this is an argument for national health care, is that physicians' incomes are not directly related to their efficiency in the managed care system. I can spend time with my patients. I may be longer at the end of the day, but my income is not directly punished. That's what I like about the military health care system. But in my colleagues who are my friends who are in practice, think I'm crazy spending 45 minutes with a patient. Why would you do that? I need to talk to my patients. They're complicated. Right. But your system that your society has endorsed certainly doesn't want to incentivize talking to patients.
Well, that's why I think that going back to the original question about trust in doctors, that you may be right, Bob, that doctors are trying to do the best thing for their patients. But the systems in place, whether it's managed care or Medicare, make it very difficult, if not impossible, to actually be as thorough as your conscience tells you you should be. And so you just order the test and don't pursue why they're coming back for the third time with chronic fatigue.
And the system, the current evolving system, makes a fair amount of doctor-patient contact with people the doctor doesn't experience as his patient, but just the current person he's interacting with. So it's no accident that as you move from a world in which, when I graduated medical school, the modal physician was in an individual practice where he had an office, people came to see him, they were his or her patients, mostly his then, and there was no question whether you had a patient or not. Now the typical doctor is an employee, not in practice by himself or herself, that frequently the patient is a patient of a group, not infrequently sees whichever doctor is up that day to see the patient. And one of the most popular specialties in terms of growing popularity in the last decade has been emergency medicine, where the typical encounter is once with a patient, and that it's heavily protocol and algorithm driven. So all of these are powerful structural deprofessionalization things. And the question is, can we develop a socialization of professionalization that will survive them? And I would say the evidence so far is a little, but not all the way. So there's a deprofessionalization of medicine because of it, in terms of the qualities of personal relationship between the physician and patient. And this is a undiscussed price of the evolving healthcare system.
We'll take questions.
Shall we open it up? We can open it up. Do you want to come to the microphone?
Come to the microphone.
We very much welcome your questions. It's great to see everyone engaged in winning science?
It's not really a question. I've been listening with great interest, but I'm one of the classicists in the room. And let's remember what Aristotle said about pity and terror, which he said are crucial in the cathartic process. And the scholar Northrop Frye kind of gave a demotic version. He said, if you see somebody run over by a car, pity is what makes you reach out to them, and terror is what makes you think, my God, I'm glad that's not me or anyone I care about. So it's hard to think of a better example than Neoptolemus of pity and terror kind of localized in one person and one situation. And I would leave it up to the doctors in the room to carry that ball further. But I was just thinking we shouldn't forget tragedy. That's it.
I have a comment to respond to that, which is, and I think there are people in the room who could also speak to this as well, but there's a theory that's been developed and is being discussed, and it's not necessarily new, but it's something that's being written about by this psychiatrist, Dr. Jonathan Shea. Some of whose students and friends are in the room today. Unfortunately, he couldn't be with us. He's written 2 books about post-combat stress and through the lens of epic. Lou, I don't know if you've read Achilles in Vietnam or Odysseus in America, but and his theory is that Greek tragedy can only be seen through the lens, understood through the lens, in Aristotle's Catharsis, even though it's 100 years, over 100 years later he's writing about it, but can only be understood through the lens of a theater by veterans for veterans. In other words, Euripides, Aeschylus, and Sophocles all saw combat. And the presumption is that a large amount of the people who were in the theater of Dionysus in the 5th century had seen combat, whether they were enlisted men or they were all the way up through. And so this idea of pity and fear resonates on a different level, and it resonates with the idea that veterans may not have a vocabulary. I think just as chronically ill patients, only being 150 years into this era of chronic illness, this epoch that has begun, do not have a vocabulary to discuss the things that happen to them or are currently happening to them. And that it's only in the presence of other people who have had those experiences in a theater with a play that deals with a wartime subject that implicitly, silently, amongst those people who are there, a form of healing or catharsis could occur.
But many of the plays don't deal with the veterans, deal with the results in the family,
Sure, sure.
No, I was just going to say, in terms of your introduction to the play, you mentioned that he wrote this when he was 86 or 87 years old, and this was one of the later plays that dealt so much with isolation. Yeah. So in addition to his wartime experience, again, I think the aging process and that isolation comes through.
Absolutely.
Can you just before you speak, can you talk about what Sophocles was going through at the time, which is really interesting?
There's a story, and again, the classicists can speak to this, but that Sophocles, at age 87 or 86, around the time that this was produced and wrote this, had been taken to court by his 2 sons and was to be declared mentally incompetent so that they could take over his estate. Sound familiar?
It's called the screech sign.
Yeah. And he purportedly recited lines from the chorus of Oedipus at Colonus, which, as many of you know, ends with a blind man, old, facing his death, wandering alone through the desert, essentially. And then said, and I'm paraphrasing, if Sophocles is mentally incompetent, then I am not Sophocles. I am Sophocles and I am not mentally incompetent. If Sophocles is mentally incompetent, I am not Sophocles. And he won the case, and his sons were censured, and he continued to write. But this is a man who clearly knew what it meant to be isolated by his family in his old age.
Yeah, I've always looked at doctors as healers. And there was some comments about we can't spend as much time with you because of insurance. At one point in time, I had a doctor that would talk to me, how's the family, and just sit and find out, with how my marital activities were and things like that. And then, that was one thing. It's gone. But insurance is still. I look at doctors as caregivers, and most of the doctors, and my doctors, most of them come from Cornell, and I always have good coverage. I've never had a doctor there at Cornell or special surgery, which I have used quite a bit, turn me down because I have coverage. But there are one or two doctors that say, I'm not taking any coverage. Mm-hmm. And that kind of makes me a little bit angry. It sort of suggests that I want the money. Mm-hmm. The hell with you. I want the money. You want to get special healing? I'm a specialist and I'm the best. Screw you. If you don't have the coverage, if you don't have the money to give, then I don't want you. And that to me is kind of cynical, and that's something that bothers me. Thanks.
May I comment on that?
Yeah.
On it. I'm in the military medical system, so basically an HMO that's government run. So I'm not directly in that system, but I have friends who tell me that one of the reasons they're stopping taking insurance of different kinds is they're trying to give a message through their patients to society at large and to the corporations. Do you see what I mean? Many physicians don't feel like they have any power. So they're using you inappropriately to send a message to Congress or someone else to say, you need to do this. Because if we say something, nobody's going to listen to us. But if patients and voters do, I don't know if this is plausible in your circumstance, but I think what they're doing is they're trying to send a message. Well, I don't know if it's true.
Following through or continuing with this theme, your feelings are important, but they're the feelings of someone who has access to health care, but not to a small group of doctors. 45 million people in the United States have no access to any doctor because they have no insurance whatsoever. Every recent poll shows that the American medical profession wants universal health coverage, even if it means a diminution of their income. They want universal coverage because they hate this social arrangement. The citizens of the United States have voted for people who don't want universal coverage. So your passion is well taken, but it may be aimed in the wrong direction.
The other tangential point I would make is just, obviously there are physicians you can't see at all, but the physicians that you can see who can no longer ask you about your family or how things are going at home may be missing the key to the diagnosis.
Just to add one more piece, in terms of our professional duties as physicians, and I think I learned this from Lou, you can sort of distill it down to two words: duty and excellence. And the duty part is social justice. So I think that certainly the profession has a sense of where we should be going, and then the question is, how can we make the system allow us to go there?
I think some of these questions, issue of rationing of medical care, I think even in this play I was intrigued by the fact that they left Philoctetes on the island. I don't think it was punishment, although you could look at it that way too, but I think it was humanitarian. I think they did it for humanitarian reasons, not to kill him, which I thought was unusual for the Greeks, because they killed even girls, just to have better military or whatever. As far as the rationing, I think it has to do with killing these sick people, such as Philoctetes. But I was intrigued by the article in New York Times today, where there is criticism that the killer in Oklahoma City received only $265,000 medical care. I mean, where do we draw the line in the rationing of the medical care? So do we kill these people like Philoctetes, or is there unlimited resources?
Just responding a little bit to that question of why they didn't kill him to begin with, which I think is really interesting. And I guess it speaks a little bit to the power of the patient, which we have sort of skirted around but haven't addressed explicitly. We've talked a lot about the system. We've talked about physicians' responsibilities. We've talked about the complexity of practicing in the year 2007 and all of the different forces at play. What are your thoughts about the power that the patient in the year 2007 has? Perhaps Philoctetes wasn't killed because he had this divine bow and arrow. Perhaps he was tricked onto the island. I don't know what the.
Well, it does say he was abandoned there because he was interfering with their libations.
Right.
Which,
they were trying to make a sacrifice, and he's screaming and.
Yeah. But anyway, it doesn't.
Yeah. Which is a real thing for them. I mean,
right.
these whether you make a good sacrifice or not will result in physical realities. So.
Well, I return to what Bob was just saying, the power of the patient. There are different kinds, but here we're talking about political or social or economic power. We're not yet at the point where most of the public in the United States is educated about medical care to the point, and educated in the political system and how it works, that democracy is really working. It's basically the difference, as I see as a personal opinion here, is that democracy is not working at the level of the individual. It's various interest groups that are working. The different factions that Jay and Madison tried to neutralize when they created the checks and powers really isn't quite working. And that I think what we hope in the profession is that since we're not happy about how the medical system is working, that people will vote for politicians who will change the system. So that's the kind of power I think that patients, since everybody sooner or later is a patient, whether preventatively or eventually because they have a problem, is that somehow the educational system will get them to the point that they will vote for what we would like to see happen. But I don't think the profession, certainly my generation of the profession, hasn't done a very good job of educating the public. I'm in internal medicine, so the American College of Physicians has only for 5 or 10 years tried to get into the public educational arena so that as a faction, the American College of Physicians is trying to get public to understand that if you want internists who deal in complex adult illnesses, very complicated illnesses that take time, if you want us to do what we're trained to do, you've got to vote for it. Because if we vote for it, if we push for it, it will be perceived as self-interest.
I mean, one other fact is that all 4 of us are in academic medicine, and the leadership, the medical leadership, tends to come from academic medicine, which is somewhat removed from these day-to-day practice situations. So I think the medical profession has had to educate itself, and then we're getting late into the game and educating our patients.
And what about in the individual physician-patient relationship in terms of the balance of power? How has that changed, do you guys think?
Well, certainly there's been a huge change in the apparent balance of power, in that only a few decades ago when the doctor was all-powerful and the patient was supposed to be compliant and take orders, and doctors would make decisions and patients were told what they were, and the patient's power was then hidden. And major power was the patient could leave. The last statistics I saw, about 35% of all prescriptions that doctors write are filled, which means about 65% are not filled, which is very interesting when you think about it. That's a form of power. If the ability to write prescriptions is a form of power, the ability to throw them away is a form of power. But in the last few decades, there's been a sea change in the attitude toward what's good medicine and what's appropriate. That's part of a broader cultural change about the de-authoritization of pseudo-authority. And the compliance adherence shift is a symbol of it. Doesn't mean much except what it symbolizes. And the notion that patients, particularly with chronic illnesses, still the anesthesiologist or the emergency room doctor is an authority, particularly if the patient's in coma. I just came from a conference on the care of patients with vegetative states or minimal consciousness. Clearly the doctor's the authority, the patient's unconscious. But when you get chronic illnesses, most strategies of treating them today, I'm going to say something no one else in the room will accept, except maybe Ed. I would say they're borrowed from psychoanalysis, where the goal is to teach the patient everything you know about his or her illness so the patient can be in charge of his own management and treatment.
But then they have to come in every day. It's not practical.
Yeah, but that model is...
But that...
I want to pick up that notion. There is growing evidence, and physicians like to use empirical evidence, that success is not what happens in the doctor's office or the hospital, but what the patient achieves in their own home. I have many patients who are diabetes. If I say to the patient, this is what you're going to do, you're going to take insulin, this is what's going to happen, I'll see you in 4 weeks. You know, it took me about 5 years of screwing up to realize that that wasn't working. You have to basically get the patient to the point where they can participate in their own care to the extent that they want to. Otherwise, you fail, and sometimes miserably. But Lyuba and I both use a system which we call the RHYME scheme. Reporter, interpreter, manager, educator. I'll basically explain that what it says is that in order to succeed as a physician, you have to educate the patient to the point that they can participate in the decisions, because they're going to throw out the prescription or not. And this is still controversial in medical education, but the notion is that if a finishing resident about to go into independent practice cannot educate the patient to the point that the patient can participate in their own decisions, that resident is not yet competent and cannot go into practice. This is a notion I introduced about 15 years ago. It's still very controversial at the student level and in the resident level, but the Institute of Medicine adopted this notion in what they call patient-centered care. And I think things are moving in that direction. Now, what it means then, and this is where I'm hoping the public will become alive with the educational process, is that the physician must not just be manager, tell the patient what to do, but educator. Then we have to give the physician time to work with the patient, and physicians have to be paid for it.
Yeah.
This requires a re-education of the physician and public along the same line. And it's an economic political discussion that needs to happen. I think the public will want that. And I think the empirical evidence is from diabetes, asthma, and I'm just talking about my own field of internal medicine, heart failure. My guess it's true in HIV, that the patient must accept and participate in the discussion or it fails. Therefore, we have to incentivize a discussion.
And sort of that goes back to that pay for performance question.
That's right. Yeah.
And just to add on to that, the notion of shared and informed decision making that is really shared, not just I want you to do this and here's the prescription, isn't really shared or informed.
Yeah, well, I must say it can go the other way though also, because the person who comes in with a cold says, I want antibiotics, where's my prescription? That also is not...
That's not shared.
Right.
Or informed.
Right.
Go ahead.
Yes, my question is about assisted suicide, which I would link to the play by the Philoctetes' Desire to Die. And I speak as someone born about 10 months after the end of World War II, hence as early a baby boomer as can be, and also a professor who therefore, as thinking in terms of the medical burden that the people my students' age will cover, as my age, are kept alive better, longer and longer. And it inevitably strikes me that here, those of us who want assisted suicide because we don't want to be kept alive in a poor quality for past 100 or whatever, have a natural community of interest with the students' age group who don't want to have more and more of their income given to this perpetuation of us. So I wonder if any of you would comment. The thought was jogged by your statement, what will the voters be doing in the future? Our voting bloc, the boomers, is very big, and I make the joke that we've tried to take on what we thought were the most essential issues of our time ever since we were undergraduates. But it may be that we have not done so well in each of the earlier decades, but that our crowning contribution as a vast aging voting bloc might be assisted suicide. So I'd like to hear your comments on that.
Bob, that sounds like one for you.
Yes, definitely.
We have some empirical data about assisted suicide. There are places where it is legal and available. And one of the most striking discoveries is how rarely it's used. So its public health significance in terms of the burden to society of the elderly or the ill is negligible. That doesn't take away from the moral question or the professional ethical question or the legal question, but it isn't an economic issue. It's too small in number. My own view is that two conflated issues should be separated. One is an individual's right to determine whether or not they live, suicide. The other is the physician's role, assisted. I don't think it's a good role for physicians. It's actually extremely easy to kill yourself. So I don't think you have to go to medical school to do it. So it seems to me that it's easy to split those roles. When physicians look at people who are interested in assisted suicide, there's several things they observe. One is a significant number of them are depressed, and if you treat their depression, they no longer are interested in assisted suicide. I feel that it sort of feels funny to let someone kill themselves when they're depressed, and I know I can treat them and get them out of the depression, and they'll say, "Thank you for helping me be less depressed. I almost killed myself. Am I glad I didn't?" And knowing that, I feel that somehow or other we should have a social structure that allows me to treat them even against their will if the relative balance is between allowing them to kill themselves when they'll turn out not to have wanted to, or keeping them alive against their will for a few extra months. The second observation is that the availability of assisted suicide leads to a very, very uncomfortable pressure from family and society for people who have illnesses that are burdensome to avail themselves of that opportunity. And I'm not sure I want to grow old in a world in which, as I get a little older and a little more infirm and a little weaker and a little more decrepit, my children begin sending me Christmas presents of books on assisted suicide. Just the pills.
I guess to tie it back to the play, it is worth noting that Philoctetes was given the gift of the bow by Heracles for having performed an act of euthanasia by burning Heracles on a pyre when he was consumed by pain by an illness brought upon him by a centaur named Nessus, and that the myth of the gift of this supernaturally accurate bow is deeply tied to the humanity, from a Greek perspective, I think, of Philoctetes' actions in choosing to euthanize this man in
And
pain.
Philoctetes was not a doctor. I'm not against assisted suicide. I'm against physicians assisting suicide.
Sure.
And Bryan isn't condoning it.
No, I'm not condoning, but I do think that the point is that it's very difficult to ask someone, it may be easy to kill yourself, that I can't argue with that, but I think it's difficult to ask someone to do it alone. And that I think maybe that's at the heart of this issue. Most of us don't feel medically competent enough to help someone kill themselves in a way that...
20 minutes on the internet.
Sure. Maybe again it's about developing a vocabulary with which to even have a conversation in a culture where it's so culturally taboo to talk about suicide, that we all feel alone when we contemplate the idea of helping someone do it.
Who was next? I didn't.
I'm going to start on the round table. There are a number of points came up in the course of this that I'd like to address, and one of them is this business of the, well, let me tell you the story. I was being vetted for a professorship at medical school and had to make the rounds of the departments, and the Department of Medicine met me after 15 minutes waiting and said, why do we need a psychologist in medical school anyway? I said, why don't half of your patients not fill their prescriptions, and the half that do never refill them? End of conversation. These are psychological issues, see? And as Dr. Jacobs mentioned, we have graduated from compliance to adherence. Medical sociologists now want us to go to cooperation, see, which is the main issue we're talking about. How do you educate your patients? But not just educate. Educate means to lead out of, you know. But to discuss with patients why they're not why they're not doing what we tell them to do, but what are they doing? See? And in teaching my students clinical work, the main thing to get them to do is to say, it's not what the patient isn't doing, but what he is doing that should be your concern. There's no not in this business. Patients are always doing something where you think they're not doing what you want them to do. Find out what they want to do. Mm-hmm. And that, I think, comes back to philoctetes, as I used to call it. Is it philoctetes? Is that the correct pronunciation? Do we have any idea how the Greeks said it?
Bill? Sounds a little heavy.
I'll stand corrected. I know they said about the Romans that no one knows how Latin was spoken anyway, so mine is as good as yours. But the Achilles' son had a point there where he changed his mind. And I think it was that he recognized that he could not any longer deceive this man who had trusted him. And no one has talked, I think, about the physician's burden of trust, what that does to you when all of a sudden the patient looks at you and says, I'm in your hands, doctor. You're not fighting. It's a terrible burden, you see. And that boy could not take it. He could not any longer be part of an untruth in his own terms. It wasn't choir good. He just couldn't do it anymore. And I think that was the power of the play, to my mind. The other is that Philoctetes' problem, I think, was not addressed by anybody. That was he was suffering a very common conflict in our psychiatric patients, that of pride versus pain. See? Shall I reward my enemies even though it causes me this pain? Wouldn't I do better to stay in this island rather than betray my principles? That's a very powerful thing. Unfortunately, rare in this climate. We don't have our political leaders asking such questions of themselves. But and one more thing, the issue of the patient asking for either assisted suicide or asking for pills or asking for anything else. To teach patients, teach our young doctors and psychologists and therapists the enormous power that the questioning form has. To teach them not to ask patients questions. Let them tell you. Don't interrogate your patients, you see. You want the patient to tell you the story in his terms, because what he doesn't tell you is as important what he does tell you. And you know the right questions to ask anyway, see. But when a patient says, can I tell you this secret? You know he's only telling it to get it off his back. And the only reason to tell a secret is to tell it to somebody else. We are enjoined to do something with this information, not do something with it. And that becomes the topic of a conversation with the patient. You want to commit suicide? You want my help? Let's talk about that. I'm not sure how the best way to go about it would be.
Very nicely said. It makes me think we usually teach our students to take a history, Oh, it's like extracting something, and there's some literature now about the notion of building a history together rather than extracting it.
Because all histories you get are lies anyway. They're often justifications of the present. When the present changes, that's the third that the history changes.
Thank you for this terrific discussion. Since 1990, I've worked with medical students and residents and nursing students coordinating standardized patient programs and training standardized patients and doing giving difficult diagnoses, taking histories, teaching breast self-exams, lots of different subjects. And in the second year of their training, medical students are very open to this. Later on, residents are open but guarded because they say, well, how can I really do this kind of model, which is very much incorporating the patient as a partner in their own care and listening to patients and educating patients. How can I do this with the constraints in the real world that are put on me because of time pressures and money pressures? And I don't always have a very good answer for these for them. And I'm just wondering if you can help me. I guess what I say is, well, I'm showing you an ideal and try to adapt it in the real world. But if you can help me know how to advocate or at least just address this reality, I'm open.
Lou, do you want to answer that?
Well, I think what your residents are telling you is what physicians in practice see, that there are certain incentives and pressures to perform in a certain way. Despite what we do in medical school, an explicit curriculum, there's going to be a reality. Gradually it's evolving, though, and I think you should be very optimistic that your work with standardized patients and helping students, residents, and even physicians in practice certain skills in interviewing, in building history together, in what we call giving bad news or working with difficult patients, is paying off enormously. And I think it's not going to be as quick as a new cure for diabetes or a new treatment for diabetes or a new treatment for heart failure. It's a gradual thing. It's going to take a generation or two. Standardized patients, been around since the 70s, but only about 10 years has your work really permeated almost all medical schools in the country. So I think you should be optimistic that it will, in fact, gradually change things, as long as the payment, the incentive system, and things that happen in hospitals. So ultimately, it's only going to work if society, through education, and I mean grammar school and high school education, the education in the country as a whole, is willing to support changes in the healthcare system and payment system. So it's not just something that medical educators, that people in the academic center can do. It's got to be a social change.
I think the other thing you can tell the residents is to be like Achilles' son and stick to your principles and don't be influenced as you go on in medicine by the cynicism of the Odysseus types around. But if, again, I think we have great people going into medicine these days if they will pay attention to their own core values.
I think, though, there's maybe something to add, which is the phenomenon you're describing and linking to the pressures of the current healthcare system was described way before the current healthcare system. Probably the most famous study of medical education was done by a medical sociologist, Renee Fox, who went through 4 years of medical school as a participant observer with a class at Cornell before Jonathan or I were there. And she coined the term detached concern to describe the attitude that medical education socializes in the medical student physician. And she pointed out that the typical freshman coming in is very humane, very empathic with patients, very concerned about their feelings, and often anti the establishment. By the second year of residency, the language has evolved, so patients are gorks or cauliflowers or they're things in beds, and they're totally dehumanized. 5 years later, there's a move back somewhere between the two. She saw that as an essential evolution of their ability to detach themselves enough to be professionally effective. The last thing in the world you want is a cardiac surgeon with his finger in your heart who's empathically identified with your pain and therefore does the wrong thing. And in order to develop that detachment, there may have to be a phase in which you're hyper-detached. And medical education may inevitably do that, although our current stresses of the system may make it excessive.
I think that the one other piece that Lou talked about and that you're hearkening to is it used to be that this was only taught or paid attention to or evaluated in the first 2 years of medical school in the absence of medical knowledge. So physicians are trained to communicate with patients before they know anything. And we are now watching them much more in the wild. We're not just watching them in the classroom, and we're evaluating them. And what Lou was talking about in terms of measuring competence and communication skills, this is a sea change. You used to, a resident would go off and become a resident, and their job was to provide patient care. There wasn't that much assessment of what they were doing in terms of communication skills. Renee Fox was watching. She, I think, was one of the few people who was watching what was going on. So I feel a measure of optimism that we are now, there are pressures from the system. On the other hand, the educational system is at least allowing us to look at what our residents are doing. Because inevitably, if all of us are going to one day be the chronically ill, one day be hospitalized, the people who are going to be caring for us are the residents. So, any concluding questions, thoughts?
I have something that I wanted. So my husband was going to be looking for a new physician. And I thought, well, not only is it important for my husband to like this physician, but I thought that it was important as his spouse that I liked his future physician also. So we made my husband made an appointment with a doctor who he was referred to, and we were ushered into this doctor's office. And the first thing that he did that I liked was that he asked me to take a chair that was not really in the corner, but away from where I knew they would be sitting. And it turned out that they were sitting just about maybe a foot away from each other, because this doctor was not sitting behind his desk. He was sitting just opposite my husband. And I thought, oh, I really hope that my husband likes this doctor, because I just think that this is really so terrific. So it was a simple move and sort of a psychological move that I thought that was really just so brilliant, because I had never been to a physician who ever did that. They sat behind the desk, and I sat opposite them. So my question is to Dr. Jacobs, who is my husband's physician. How did you...
How come you can't afford an head to this?
It's feng shui.
And I'm not a plant, but I'm just so curious, because I haven't been back with my husband again to be able to ask you this question. You know, so where did this terrific communication skill come from?
Well, thank you. It just makes sense. You know, if you want to establish a connection with somebody, if you don't have perhaps as much time as you need, why not do something simple like sitting next to them?
That's great. And I think that's a great point, is there are simple things to do, and it's even more important to do it well now that we have less time. Because a lot of people will say, oh, I don't have time to communicate effectively. And I would argue that's why you need to communicate effectively. There's no time for...
Yeah, that's right. So I want to preface my question by saying that I'm one of these people who does everything to stay healthy. You know, I stop smoking, I eat the right foods, I work out five times a week, etc. Now, do you, when you see patients, I have a sister, by the way, who smokes, who has diabetes, who has all of that stuff. And I have a problem discussing this with her, but what my question is this. When somebody comes to you who's starting to gain weight or who hasn't stopped smoking, do you feel it's your responsibility, and do you have the courage to tell them, hey, look, this is what you've got to do? Just from that end, not pushing pills, but just taking care of their bodies. Thank you.
I will say quickly, yes, absolutely, and it pays to ask on a repeated basis. On the other hand, I think you also have to ask a person who is gaining weight, who knows they're gaining weight, doesn't have to be necessarily confronted by somebody saying, you know, you're obese, you're going to have this problem. Maybe you can, you know, say in a gentler way that, you know, I think your blood pressure might come down a little bit, your cholesterol might come down a little bit, you know, if you lose weight, because sometimes in that situation, the person is so embarrassed by their weight that they won't go see the doctor in the first place. So I think it has to be a clear message, but one that also a person can live with.
I think also our participant who talked about the fact that it needs to be a conversation, and you need to begin by understanding why this is happening, is a really important piece. No, you don't.
But
nor would they usually, and usually they won't.
But psychiatry and psychology, like the gentleman before, have contributed enormously to the education of all physicians, surgeons, pediatricians, internists. If Neoptolemus can say to Philoctetes, what is it you want to see happen? You know, that conversation, what do you want to see happen? What would be a good outcome as far as you're concerned? If you have the training to do that, and the time to do it, and the physical conditioning, your positioning in the room allows it, then all of those things can come together. But as we see in this case, there's all these different pressures on everybody, on the physician, on Neoptolemus, on the patient, Philoctetes, the social situation, what the generals in the system want, that you're lucky when all those things converge. But I think there's a growing conversation within the medical community, certainly in the medical education community, on what success would look like 10 years from now for the physician.
I want to thank you for that, for the honesty here today, for the slight mention of the healthcare system, for your frankness. I really didn't expect that, and it's very refreshing.
Thanks a lot.
And that we're all on the same team.
Thank you.